A 50-year-old man comes to the clinic because of progressive upper abdominal pain over the past 8 months. He describes the pain as gnawing, worse after meals, and radiating to his back. His medical history is significant for 20 years of heavy alcohol use. He has unintentionally lost 7 kilograms, 15 pounds, during this time, despite normal appetite. He has had 2 prior hospitalizations where he had far more severe abdominal pain with vomiting. He also reports frequent foul-smelling stools. On examination, his BMI is 19 kilograms per meter squared. Laboratory studies show hemoglobin A1C 7.9%, serum amylase 45 units per liter, normal range 25 to 125, serum lipase 28 units per liter, normal range 10 to 70. Which of the following most likely describes this patient's underlying issue? Choice A, malignant change in pancreatic tissue. Choice B, prolonged inflammation from formation of fluid-filled sac on the pancreas. Choice C, open sores formed on the gastric mucosa. Choice D, long-term damage causing disruption in exocrine function. Or choice E, damage to epithelial cells causing an abnormal D-xylose test. I'll wait 5 seconds and then begin answering the question. So you have a patient with abdominal pain that's worse after meals and it radiates to his back. So right off the bat, you have alarm bells going off for pancreatitis. Sometimes if they want to give you a tricky question, they actually won't give you the detail that the pain is radiating to the back. But of course, a lot of the other stuff in the question will point us that way anyway. You got the heavy alcohol use, and he has weight loss, and of course he's been hospitalized before with what sounds like acute pancreatitis, really bad abdominal pain with vomiting. So it says he has foul-smelling stools. Usually when MBME tells you foul-smelling stools, you should be thinking steatorrhea, which is fat in the stool. If they want to be easier on you, they'll tell you greasy stools or stools that are hard to flush, stools that float. Obviously, fatty stools could have a lot of different causes: giardia, cystic fibrosis, issues with the gallbladder. Anything that can cause malabsorption might cause steatorrhea. So anyway, you got the lab values here. You got the high hemoglobin A1C. I'll come back to this in a second. So more importantly, you'll see that his serum amylase and lipase are actually normal. So very clearly, if you have this pancreatitis picture and you have what looks like normal pancreatic enzyme level, and he's had this history of heavy alcohol use and acute pancreatitis in the past, everything is pointing us towards the idea that basically what has happened is that his pancreas is burned out after repeated trauma and inflammation. So this is chronic pancreatitis. And if you go through the answer choices, you'll see that choice D, long-term damage causing disruption in exocrine function, is the correct answer. It's the only one that describes chronic pancreatitis. And just going back to hemoglobin A1C real quick, some of you will be confused by this. And it's actually really simple. If I have damage to the pancreas and it's burned out and can't do its function anymore, then obviously that's going to affect my glucagon and insulin functions, which can lead to diabetes. So let's quickly look at some of these other answer choices. Choice A, malignant change in pancreatic tissue. Obviously, I'm talking about pancreatic cancer. Pancreatic cancer is actually pretty well known for being really hard to detect because it doesn't present with like these big symptoms. A lot of times what you'll get is just this painless jaundice. And on USMLE, what they like to do sometimes is that they'll give you a patient with jaundice and they'll tell you that they had their gallbladder removed in the past. And it's like, how could they have jaundice if they don't have a gallbladder? And the answer will be pancreatic cancer, because the pancreatic cancer is compressing on the common bile duct. Anyway, coming back to this question, pancreatic cancer wouldn't really explain the steatorrhea. So next one, choice B, prolonged inflammation from formation of fluid-filled sac on the pancreas. This was me being a jerk and trying to trick those of you who saw that this was a pancreatitis immediately, and you decided that choice B was the right answer because it's the only one that says pancreas in it. The MBMEs actually do this sometimes. They'll have one answer choice that repeats words from the question as a trap answer choice. So you don't want to overthink questions, but you do want to be careful about what you're picking. Anyway, choice B here is referring to a pancreatic pseudocyst. Pancreatic pseudocyst is pretty important. If you get a patient where they have acute pancreatitis and it says they've been given bowel rest and IV fluids and they've been getting better, but then all of a sudden they still have kind of a fever and possibly abdominal pain, and if they're nice, they'll say there'll be some kind of epigastric mass. So basically what has happened is that acute pancreatitis has caused trauma to the pancreas and has formed a pseudocyst. It's called a pseudocyst because the walls of it is not pancreatic tissue. Rather, it's vascular and fibrotic tissue, and it's filled with pancreatic enzymes and blood. And it can cause kind of this persistent inflammatory reaction. You treat this with ERCP. Basically, you just stick a tube up there and you drain it. Choice C, open sores formed on the gastric mucosa. Obviously, this is just peptic ulcer disease. You typically wouldn't have steatorrhea from this. Not much else to say there, I think. Choice E, damage to epithelial cells causing an abnormal D-xylose test. Classically, this would refer to something like celiac disease. But the point is that you should understand that the D-xylose test is used to test the mucosal lining, basically to help you narrow down what the cause might be if you see a malabsorption. So there is a malabsorption here, but there is no reason for you to believe that there's anything wrong with the GI mucosa itself. It's because of the disruption in exocrine function by the pancreas, right? I don't secrete the enzymes needed to break down the fats in my food, and therefore I see it in the stools instead. So bring it back. If you see a patient with a pancreatitis picture where they have abdominal pain and it radiates to the back, history of alcoholism, but it doesn't look that bad. It doesn't look as bad as acute pancreatitis, but they also have steatorrhea, normal pancreatic enzymes, and other stuff that might come from the pancreas losing function like diabetes, then you would think chronic pancreatitis. I hope this video was useful. See you in the next one.